Alrighty, hello and welcome to the Peak Endurance Podcast, and welcome once again, Luke.
Thanks again for having me again, Isabel.
Yes.
So happy to be here.
Well, look, there's so many runners' injuries that we can discuss. I'm sure there's going to be plenty of these.
Well, yeah, we're going to tick off another one today. So and probably one of the bigger and more popular ones today, actually.
It's even been named after running. So runner's knee.
Runner's knee, yes.
Talk us through that one.
Well, runner's knee is what it's more commonly known as, but it's also known as patellofemoral pain. And it's a big one in runners, responsible for close to 50% of all running injuries.
Wow.
Are related around the knee. Unfortunately, women get the short end of the stick there, but it is more common in females. But a really, really common one, something that we see and treat a lot, and that I'm sure that a lot of you, purely by numbers, would have experienced this condition at some point.
So can you tell us, I'm assuming females get it more because of their hips?
There's a few reasons why. So there's theories around that. There's greater predisposition to more laxity there, so not as high a strength, but then, like you said, the pelvic width there and the knee angle. So there's a few theories as to why. Also how they move. The movement patterns of jumping can also be a bit different from males to females. So there's a few things that have looked into that, but we'll sort of explore some of the the contributors and also some of the tips to help manage this condition today. So it's also known, runner's knee is also known by the technical name of patellofemoral pain is what we tend to call it medically. It happens in a wide variety of ages. So we see it right across from, and often a lot of people that have experienced this, it can start in teenage years. So we see it especially in the younger girls and more active girls and boys. But it can go right through life. We used to think that it was what we call a self-limiting condition. So that's something that you just have and then it just goes away by itself. But we actually know that a lot of people that get this can have this for a very long period of time. And so it can really hang around for years and years if nothing is done, about it.
You've got there on the slide, chronic ongoing pain up to 20 years post-diagnosis can occur.
Absolutely, yeah.
Wow,
yeah. So it's a big one. So it used to be something that years ago we thought, look, it's one of these issues that's settled by itself. But we know, and we can often trace when people have had this issue, we see it starting back when they're teenagers or in their younger years, and then it's just never gone away since then. So we're going to talk about some of the tips to help to get on top of it and make sure that it doesn't become a persistent problem that hangs around for years and years and affects your running. So some of the symptoms that we see with it, so quite commonly people describe pain around the knee. So it's usually around the front of the knee with patellofemoral pain. So they'll sometimes draw a bit of a C-shaped sign around the inside there, or it might be underneath the knee or just around the kneecap, and it can shift and move around in different locations. Common aggravating activities for it tend to be running, so they can complain that it gets sore in a run. Sometimes they can warm up. Sometimes they feel a bit stiff at the start. It gets a bit better, but then by the end it can be quite sore. And then later on that night, it's really, really aching, or waking up the next day with it quite sore. Lunging is another one. So for those that are doing any sort of strength training there, jumping, stairs, that's another one. So not just going up, but often going downstairs. They find it really quite hard on the knee to do that. Then we've got hills with hill running. We'll talk a bit about that. Squatting down, so if they're bending down to pick something up, they might notice that it's pretty achy and sore when they're doing that. And sitting as well, believe it or not. So sitting it's actually this condition is also called moviegoer's knee, because a lot of people with it have issues with sitting for long periods of time. They're sitting in a movie and they're like, I just need to stretch my knee out. Need to get some movement in through there. So sitting is. So
if you do have this condition, it can be quite debilitating for general life.
That's exactly right. We're not just talking about it affecting your running, but it can carry over, as you said, getting up and down the stairs at home, or looking after the kids at home, those sort of things. It really can. So it can be, and we see it on a spectrum of severity of these. We see from the very mild to the really severe, where it's really impacting their life. Absolutely.
So it pays to get on top of it.
Absolutely. And one of the things that also tend to accompany the knee pain is clicking around the knee. And so a lot of people will say to us, oh, my knee clicks. Is that a normal thing? It clicks and grinds. It feels like there's, bone grinding on bone there. We know that noisy knees are actually normal and they're very common. So
if our knees are clicking and there's no pain at all, that's perfectly okay.
Yeah, nothing to worry about. And then even if they are clicking and it is painful, it's very unlikely that clicking is actually contributing to the pain.
Okay.
Just a coincidence there that it's happening.
Yeah.
But we know that the 1 in 3 pain-free women, so that's 1 in 3 that don't have any pain there at all, will have clicky knees.
Yeah.
And that the noisy knees is also not a sign of severity as well. So if you've got those with noisy knees, were found in a study to have the same amount of strength and the same amount of function as those that didn't have clicky knees. So don't worry about that. Rest assured, what that noise is, there's a few things that it actually can be, but a lot of the times what it is you've got your kneecap and you've got your thigh bone, and as they move over each other, you can get some moving around of fluid and some sort of squelching of fluid that happens through there. So that's what make it sound like, there's sand in there, or it's actually just a squishing of that joint fluid. So that's but there are also ligaments and tendons around it that can flick around, and again, they don't cause any harm. So if anyone out there has got clicky knees, you can be confident that it's not causing you any issues there. So
that's good to know.
So as you said, it's important if you've got this to get a diagnosis. There are a lot of things around the knee that can cause pain around that area. Things that you can have tendinopathy issues around through there in the quads and the patellar tendinopathy. Things like plica, you can have meniscal irritation, you can have fat pattern irritation, you can have referred pain from the hip and the knee or hip and the back. So it's a lot of things that can be. So it is important that you do, get a diagnosis of what's going on there. We always talk about that, and that's important because that helps to then dictate what the best management is. So so we're going to cover our 4 tips for our listeners and viewers today for runners' knees. The first one we're going to talk about is running loads. Then we're going to talk about strength training. Then we've got running technique, and then lastly, taping, which can be useful to help to offset that and relieve some pain.
So does increasing our load too quickly, can that lead to runner's knee?
Absolutely right. That's what we're going to talk about first is running load. And running load is really, really important. We've mentioned it before in some of our other talks.
Yeah.
If you're not getting that right, if you're doing too much too soon, then that can really, not just specific to the knee, but it can cause all sorts of issues.
Well, I have noticed that in our discussions that it tends to follow from a big jump in load is some injury or other. So that's why it's so important to keep such a careful eye and just gradually increase. Exactly right. And that's where, the advantage of having a coach, of someone to look after, is they're taking all that into consideration. They're increasing your loads at a reasonable level. They're making sure that if whatever happens, you have a bad week and you weren't able to do much that week, they're making sure that the next week that you're not ramping up too quickly. Because that's often what we see. It's sometimes not people just saying, I'm going to go silly this week. It's more like, last week I wasn't able to do much. Work was hectic. I had a cold, hopefully not COVID, and I just, wasn't able to do much. But next week, you know what, I'm going to make up for it. I'm going to get into it. And so it's make
not
up
always,
all those kilometres.
Yeah, that's exactly right. So it's the troughs that sometimes then cause the peaks. We've actually got a bit of we'll skip forward to this one through here, and that's why we're talking about that. But that up and down there, if we're looking at weekly mileage and weekly training now, it's these peaks and troughs that tend to cause the issue versus... That's why we discussed consistency is the most important aspect of training load. It really is. And that's, consistency is obviously the best thing for fitness, but it's also the best thing for injury as well. Just a periodized program where you're gradually increasing, having the occasional down week there to absorb and recover from that training. And that's, unfortunately, it's very rare to meet recreational runners that are doing that right, and that's why they're often coming into me injured because they don't have that right. They've got no direction. They're just sort of doing their own thing, doing what they feel like, doing what they've got time for, and it results in these, these ups and downs, which we see in this graph through here. So that's definitely a big one that we see, too much too soon. So being mindful of that, week on week, how you're increasing, and watching for those troughs there that you're then not ramping up too much the following week. If we have a look and see, I think we've used this slide before in one of our other talks, but, we don't have to stop running. We're talking about running load here. With this condition, most of the time you can continue to run with it, thankfully. Well, that's good news. It is good news. So, and like for a lot of other conditions, we tend to use a pain scale for this. So what we tend to say is, around anywhere from under a 4 or 5 out of 10. So if we say 10 out of 10 is the worst pain you've had, 0 is nothing. If we can keep it around, below that 4 or 5, then we're pretty safe. If we can keep it during the run and then after the run and the next day, so making sure that we don't have a big flare up there, then we're good to go.
Yeah.
So pain, it's okay. It's safe. You're not doing any damage with this, with running with this. And a lot of runners are often relieved to hear that, because it means
it sometimes sort of feels like you're doing damage, though.
It does.
I think that's what the fear comes from.
Exactly right. And that's where we can, relay that fear and saying, no, look, this is what it is.
Yeah.
We're not going to do that if we stick to these guidelines and then we can avoid running into trouble and causing a really significant flare up with this. So
but when you say as long as the pain is under about 4 or 5, what about doing like sprints and those sorts of things? Should we just keep it easy running, or can we do the variety?
Yeah, well, you've actually, that's a very good question. We're going to talk about that soon, because that is a good question. And if we jump to that now whilst you're on that. So
I'd be interested to know about the hills too.
Yeah. That's another one. So we talk about with this condition, volume or speed. Now, typically when we're dealing with an injured runner, most of the time we sort of just focus on, we take out speed and we focus on volume. However, knee issues, and this one in particular, is one of those ones where you can buck the trend a little bit, and you actually can introduce some early speed work, and it's generally tolerated okay. Because what happens is, as we run faster, a few things can happen, but we tend to land more in sort of a forefoot or more towards the front of the foot there. Our cadence can increase a little bit there. And what that does is it shifts the load away from the knee, and it can put it down more towards the calf and the foot. So it actually can take the load away, but it does put more load obviously in through the feet and the ankle. And so that's where with things like we can, depending on the injury, so for things like an Achilles issue or a plantar fascia issue, that doesn't tend to tolerate speed work so well. But knee issues and runner's knee are one of those ones that you can potentially add some speed in early on. And again, just seeing how they respond, keeping it below 4 or 5, we're good. So we often don't need to take that out. But it's more the volume, it's the time on feet, the longer runs that can have issues with this runner's knee. So that's the answer to the question around what do we do? Do we change the volume? Do we change the speed? I'd say reduce the volume a little bit. See if you can keep the speed the same, and keeping those symptoms within a manageable level there. If we talk about then going on to hills or flat, now we mentioned before some of the things that will tend to aggravate this are stairs and hills. And we often see this come on after a hillier run. And it's not always the uphill that gets you. It's actually quite often the downhill. And I'm sure, yourself, Izzy, that's quite so used to the hills there. Running hard, running fast downhill is really taxing on the quads.
It's much harder than uphill.
It absolutely is. And so there is a lot of that. And the reason being is that there's a lot of braking force involved there as we're going down. And that braking force is taken by the quads and the knees, and so a lot of these, and this has happened to me before in the past, where I've done a hillier race and I was going harder down, and you feel it in the knee, feel it in that knee a bit afterwards. So we tend to say keep it to flat for the time being until we get a hold of the symptoms, and then we can start to introduce some hillier runs there, preferring to, and I will tend to go harder uphill, but then slower downhill to manage that, and then you can start to increase the speed on the downhill parts as the knee and the symptoms settle. So that's with the running loads there. So making sure we avoid those spikes. We've got you can often reduce a bit of volume, keep the speed going, and then also just going on the flatter runs. Now, the other thing that we like to do for this is strength training. Now, one of the things is that, there's no real blanket rehab for, you've got knee pain, go and do these exercises, because, and our approach is very much an individualized approach, because in one person with this runner's knee, they may have, weakness in through the quads, but in someone else, it may actually be that they've got weakness in through the hip or in through the calf. And so it's important to individualize that. And so that's where we by a proper assessment and working out what the strength deficiencies are, you can then target exercises into those areas. And then we choose the exercises according to what you can tolerate and what you also prefer and what you've got access to. You know, have you got weights at home, or what can you do? So that's some of the things that we take into consideration when we're determining what exercises we're going to give you. But we'll run through some of the key areas that we look for strength and some of the options that we've got there with this. So firstly, the quads, okay, and no, this is not me. The picture's here, so but probably both my legs would be about the size of one of those. So, but the quads are a big one. Obviously, you know, the quads are our thigh muscles down here. They go down and attach into that kneecap there. So the stronger that we've got these thigh muscles in the quads, the more pressure that we can take off on those knees there. So a couple of things there. I mean, one of the things that our listeners may have heard of before is, you know, talking about what's the VMO muscle, or what's called the vastus medialis obliquus. And this was, you know, something that years ago we thought that, oh yes, no, if you've got this knee pain, then you need to be targeting the VMO, working on these ones, you know, this tiny little muscle inside the knee. We now know that that's debunked. So it's not, we don't need to focus on the VMO. Okay. We throw that one out. It's actually just generally getting around through the quads there. And so you don't need to worry, because I mean, when I initially started practice, you know, 17 years ago now, that was how I was taught and what we were teaching patients. It's the most frustrating exercise to do, to get this little contraction going on the inside through there. So for anyone that's still attempting to do that, you can throw that away, just get the quads strong. So some of the options that we've got for the quads there, we've got squats, and that can be generally better tolerated in the shallower ranges. So, you know, in the shallow ranges there,
you don't need to come down into full on.
No, and in fact, because that's where there does get a little bit more pressure as we go a little bit lower, and so that's why we tend to keep it a bit shallower for those that have got that knee sensitivity. Although for some people, they actually find they go better in the deeper ranges. So I always put a caveat on that one. Most people tend to be shallow, but some people actually, the shallow range is the most sore part. So we actually, for those people, we get them just working in that deep range. So again, it comes down to the patient's tolerance, you know, what they're feeling, that the pain in that particular movement. Squats will tend to start off with firstly a back squat or a goblet squat there, but usually a back squat. And then going on to a front squat, because that is more demand on the knee and the quad through there. But the other alternative we've got there is a really elevated split squat, also called a Bulgarian split squat. So
you did say that lunges can cause aggravation of it, so that the elevated split squat doesn't aggravate?
No, because it may in some people, and that's why we always come down to individual preference there. But there's ways that you can tweak that, and you can change the foot position, you can change the distance there. So and that then will lessen or increase the load on the knee. So there's lots of things you can tweak with that exercise. But for some it's not good. But for others it can actually work beautifully. And then going onto what you just said then with the lunge, there are ways to actually modify the lunge to make it more knee friendly. So actually doing and this is backwards people when we do this, but if stepping forward into a lunge hurts, you can actually do a reverse lunge and still standing on that side. And it's the same position. If you took a photo of the start and the end position, it's the exact same. But what we've got in the forward lunge is we've got the impact of stepping forward, whereas in a reverse lunge, that's not there. So
because when you're stepping forward, you kind of all your body weight forward into that knee.
That's right. And then the quad and the knee, you're having to decelerate that leg there. Whereas if you're just standing on that leg and you step back with the other one, you're still ending in that same position, but you don't have that load there. So you can turn a lunge into a reverse lunge, or you can change the different leg, you know, a slightly different leg position. You can step out a little bit further. So lots of things you can tweak with that.
So is it better to have a lunge that goes at further distance, or keeping it closer together?
So generally, if you go a bit further away, it does get a bit more in through the back of the hamstrings there, and the same with the split squat. So if you're having the foot further out in front, you tend to get lesser knee angle, whereas if you bring the foot closer to you, then you tend to get more bend in the knee, a greater knee bend angle, and that can put a bit more load through there. So that's also how we can progress it. You know, if people are really sensitive and irritated there, start off with a position that's not so bad, and then we can progress it into ones that are a bit more challenging. Then we've got the leg extension machine. So we really want to isolate that. So that quad, that's, you know, getting on the machine there and kicking the leg out in front. That tends to be tolerated in again, sort of more the starter ranges. So they don't tend to like that when that goes fully to lock out and fully straight. That can often hurt them. So if that does, then we just stick within the ranges that are you know, within that. So
it's still a beneficial exercise, even if you're not doing the full range of motion.
And actually it's a very good, you know, it's an isolation exercise, but it can work really well for getting that quad strength up, because it's just purely getting that quad working. And going single leg on that as well too. So make sure that you're not taking over with the other legs.
Yes,
so,
I do remember being told to do it with the foot on the angle to get the glute motor.
Yeah, so that one, it doesn't matter so much.
Yeah.
We just want to get the quads working. You're not doing any harm by doing that, but you just don't need to. It's just getting all four quads going there. So then the other one we've got is the leg press as well. So leg press machine, and again, that tends to be better tolerated in sort of from the not too deep in the starting position there. So it's more, as the knee tends to get a bit straighter, it tends to be much like it would be with a squat. We spoke about before, the squat's a bit shallower, and they like that a bit more. But the leg press is another option there as well. So you've got a few options there to go through the quads. My preference is if we really need to get the quads going, I prefer to use the leg extension machine to really isolate that. But combine it with one of these other movements there, whether a rear leg elevated split squat or a lunge, and then going from that there.
Now with leg press, what about, would you be having it where you're facing the plate, or is the 45-degree one better? Which one would you recommend more?
Either or actually is okay.
Yeah.
Either or is all right. So just again comes down to comfort, and sometimes you find that they're better on one versus the other. So you can actually, if you've got access to both, try both, see which one feels more comfortable with the knee, what allows them to do greater load on that. And again, single leg, coming down a single leg on the leg press. What feels more comfortable for them. So, because some people even, on their back, it might not feel as comfortable in one position. So all these other things you can take into consideration there as well. Then we've got the calves. So the calves, one of my favourites here. The calves, we can't forget these. So calf exercises, we've got our simple calf raises there. So obviously doing that with weight, we can do that single leg, lots of different ways we can do that. And then we've got our seated calf raises as well. So
how does the calf strength impact?
Yeah, so calves calves are, we've spoken before, are the number one muscle involved in running, in terms of they take the greatest impact forces. Now, if they're not taking it, then something else will. And that's where things start to go up the chain there. So there's also other things that happen, in particularly when we're in what's called mid-stance. So as we're running through, our foot hits the ground and then our foot comes underneath our body. In that position, if the calves don't lack sufficient strength, we tend to get a greater knee bend, which can then put more pressure around through that kneecap there. So the seated calf raise is a good exercise to really isolate the lower calf. That's my preference. If people can get access to that, I'd like them to do that.
So you would, if people can only do one calf raise, it would be the seated.
Seated, because it just tends to get a greater activation of the lower calf muscle called the soleus. Whereas the standing one, you get a bit of both. So you're still going to be doing something, but the lower calf muscle, that soleus, is actually the more important one out of both those calf muscles there. So, and obviously lots more different options we can do for the calves, but these are really just two simple ones that we can get people doing if they to build up strength there. And the great thing about this one is that they really, no matter how irritated the knee, if the knee's really irritated, they usually can do a calf raise without any problems, because there's no bend in the knee for even for the seated calf raise with the knee bent. It's generally pretty well tolerated, standing calf raise. So for the most angriest knee, we can get them started doing this stuff to get some strength around through there. So that's the calves, the second one there. Then we've got around our hips. So we've got to around the glutes, they can, and there's some research to show that weakness around through the hip muscles there is found in those with patellofemoral pain. So it's an important thing that we want to address, and especially these hip muscles on the outside of the hip there, what's called the glute medius. So they are important. Exercises that we can do to tolerate those are your sumo, your crab walk. So that's your bands around your feet, and then walking from side to side, or walking from forwards and back there. We've got our side plank. So actually just holding a side plank there puts a lot of work into those muscles on the outside of the hip. And then you can do things in that position like raising the leg up, moving the leg around, doing those sort of different things there. So that's sort of putting work into the outside of the hip. The rear side, so sort of into the back side in the big glute muscle, the glute max. That way we can get things like bridges, so doing bridges and hip thrusters, deadlifts as well. So those ones there can actually work quite well for working around that hip. So again, lots of options for there. But one area that we don't want to miss in terms of assessing, but then strengthening around there for those with knee pain. Then we've got our feet. So the feet down the bottom through here. So I can't forget the feet muscles. They're the ones that are making that initial contact there, and they're our foundation. So we want to make sure that they're right. We've spoken a bit before about the feet, but simply doing things like toe yoga, which is, spreading the toes apart and wiggling the toes around, a good way to get those feet up and firing. And then we've also got banded toe exercises. So doing those exercises, with the band around the toe, and then bending the toe down to the ground, or putting the band around the remaining toes and pushing them down to the ground as well. So all to get that
sounds good.
Yeah, or to get that underside of the foot going there. So, and there's lots of other ones, even doing the calf raises we mentioned before, the standing calf raises or the seated ones, we'll get some work going through those feet muscles there. So a few areas to consider, and which those probably the four more common areas that we find with weakness with this runner's knee. Then we're going to talk about running technique. So running technique is certainly something that we assess, and it's something that should be assessed in those with runner's knee, because there can be common technique faults that we can see, and actually changing technique can be quite beneficial for those with runner's knee. So in fact, a lot of the research that's gone into running gait and changing running gait has been looking at those with patellofemoral pain or runner's knee. So a lot of the research has gone into this, and what they've found is that they've found that changing technique can result in beneficial improvement. So and that can be even having them running, give them some things to change, and the pain can actually decrease there straight away. So
I always often have heard that you shouldn't change your gait, that your body knows the best way to run for your body. What do you have to say about that?
It's a really good question, and one that we hear often as well. So firstly, you don't just want to be changing your technique for no reason. You've got to have a good reason to do it, because if you're going to be changing, and this is on the second point here, we've got to consider how changing your technique is going to impact other areas. So just the fact that say a common one might be, I hope it's not being used, but changing your foot strike, how you're landing on your feet. It's something that a lot of runners will do. I don't like that. I don't use that as a cue myself. We can explain a bit more why, but by changing that, you're changing where your body is taking the load. Load just doesn't magically disappear. What we're doing with changing someone's running gait is we're changing where those forces are being redistributed to. So for instance, in those with knee pain, what we're doing is if we're changing someone's technique, we're shifting the load away from the knee and we're putting it somewhere else. And that somewhere else is usually down and through the calves and the feet. So you've got to make sure that if you're going to be changing this, have you got the strength down there to be able to take that? Which is
why you were saying that it's important to strengthen those areas as well.
Exactly right. Yeah, all these things are done at the same time. It's not just, just do this and you'll be fixed. It's often, multi-pronged. You need to be doing this, you need to be doing this and working on this at the same time. So, but then going back also into your other point there, you're asking about, can running technique be changed? It absolutely can be changed. And the research has actually shown this too, in that they've given an intervention, told them to go and change this, and then they've followed them up at 1, 3, 6, and 12 months time, and found that those changes have actually been sustained. So running technique can be changed, but it doesn't mean it needs to be changed. So always got to consider that. But that is that's a common question.
And I'm guessing that if you're going to be thinking about changing your gait, that you should do it under guidance rather than just doing what you think.
And that's exactly right. And I have seen that gone wrong, where people have read, coming back to that foot landing, I've read that I need to change, I'll be 4-foot striking. And this particular runner came in with calf and Achilles issues, and not surprisingly, because he was all of a sudden running on his tiptoes essentially. So, and we don't want to be doing that. So you do have to be careful with it. That you do realise that you are, by changing this, you are redistributing those forces, and you may create other issues. So yes, it's always better to do it under the guidance of someone that knows what they're doing. So some of the things that we see, there's lots of, I guess, technique faults or things that we look for in those with runner's knee or patellofemoral pain. So one is we look to reduce the up and down movement, so which we call vertical oscillation. So it's the sort of the really bouncy runners, they're going up and down.
So you find the bouncy runners tend to have more runner's knee.
They do, yeah, because what happens is they go up and then they go down and they really sink down. You know, they've got a high degree of knee bend there when they're doing that. So that's one thing we try.
Just thinking about it hurts my knees.
Yeah, exactly right. And that's where, you know, the guys tend to be the more common ones here. You know, they tend to think that each step is a rep. You know, they need to be pounding out and jumping up as high as they can. So yes, guys, this is more often than not, this is a common fault we see in them. The other way that we can do, and this can change a whole lot of things there, is increasing your step count, or what's called cadence. And there's been some research that's looked at this, and increasing that by 5 to 10% has been shown to decrease knee loads. But as we said, you know, it's taking it away from the knee, but it is putting it elsewhere. So it's putting it down through the feet and the calves.
Yeah,
there.
I mean, I have heard that from yourself, but from other places too, that if you increase your cadence, you will reduce a lot of injury.
Yeah.
I also assume that's because you're putting less force through each step, because you're distributing over more steps, the load. Would that be part of it? That's
one theory. And look, there's some, you know, there's still, it's an emerging area in terms of, you know, does increasing your cadence reduce your injury risk? The question hasn't been fully answered yet,
okay.
but increasing cadence can, you know, create changes for things like this or others. But there's a couple of things. Yes, it can reduce those impact forces. So by increasing the cadence, then you're not hitting the ground as hard, but it can also reduce what's called overstride, where you're landing a long way out in front of you. And that's where, you know, we've got here. So we've got reducing the impact loading. So by increasing that cadence.
And I'm guessing you can't bind something down as much as well.
Exactly right. Yeah. So you tend to see that reduce in vertical oscillation. So pretty much a lot of this list that we're going through there are affected by increasing the cadence. So it is a common one that is used, and can be a very simple one to implement as well, to change a whole variety of different things. The other thing that we want to look for is what's called peak hip adduction, which is basically, if you're looking from a runner from behind, it's the knock knees. You know, it's the knees coming in towards each other, and trying to encourage that not to happen. So trying to encourage a little bit of a wider step for stopping those knees from bumping into each other. So that's something another thing that we look for there. And there's been research that's looked at women with that. It is more common in women to see that. Not exclusive, but yeah, that's something we look for with these runners. Then we look for something that's called a knee strategy, or the knee forwards on the toes, and that's when I mentioned before, with those runners that tend to go up and down a lot. You know, they're up in the air and they come crashing down, and they've got a lot of knee bend when they're in that mid stance position, and so that sort of puts a bit more load in through the knee there. It can be a sign that they maybe lacking the strength in through the calves there to support that, because
the calves will sort of counterbalance and pull it back a bit.
That's exactly right. So that's something we look for. And then, you know, one of the other things that we can do is we can get people leaning forwards a little bit more. That can do a couple of things. It can get sort of more hip involvement, so get more hip muscle activation there, but it can also help to reduce a bit of overstride. So instead of, you know, by leaning forwards, it's harder to land out in front of you. So these are some of the things that we look for there. Foot strike, you know, put a question mark there, because I don't personally like using that as a cue, saying, Isabel, I want you to run your forefoot. Yes, it's going to take some load away from the knees, but it really is going to load the feet up. And a lot of runners find that very hard to make that transition, and you often cause more problems than you solve by getting them to do that.
So you're saying, because everyone's always saying, you know, oh, you mustn't heel strike, you mustn't heel strike. If you are a heel striker, should you be so paranoid about that?
No, absolutely not, because most runners are, you know, over 90% of runners are heel strikers, and even a lot of the elites are heel strikers. I mean, as we start to go faster, we do land more towards the front of the foot. But no, most people are heel strikers. There's what we call, you know, good heel striking and bad heel striking. Bad heel striking is where you're really reaching out in front of you, you're landing way out in front, you know, overstriding there, and you're landing quite heavy on your heels. That's not so good. We like to what we like to see, you know, a good heel striking is bring that landing a little bit closer to your body, so you're not landing with a straight leg all the way out in front. Got a bit more knee bend and landing a bit closer there, and that's the heel striking that we like to see. So no, there's nothing wrong with heel striking. So that's a big myth that we can clear up.
That's good to hear. So you know, us runners that do heel strike, and you know, it's not all bad.
No, it certainly is not. So don't worry about that. You may see, like, as you start to create changes, and sometimes by changing cadence, you might see some slight changes in foot strike. You know, instead of being a really heavy heel, they're more a lighter heel, or moving towards
it's
the
a lot
midfoot.
harder when you're bringing your feet in, you know, closer to heel strike. That's
exactly right. So we can sometimes see that, but it's never a cue that we'll use to say, get up on those toes. So the next one we're going to talk about, and this is the last one through here, is taping. And taping can be a really good one, especially for those that are just really agitated. It's really sore, and we just need to quieten it down. It's a really simple technique that our listeners can do at home. All you need is a couple of strips of tape, and you can use just your sports tape, or you know, your strapping, your kinesio tape, the stretchy tape there. Guys, I'd recommend you shave your legs because it doesn't feel so nice pulling on the hairs there. Take that from experience, especially when you're taking it off. But yes, if you are going to do this, I'd recommend just shaving a bit off on the top of the knee there. And then all we're doing is we're really just putting 2 strips of tape over the knee there, and just going from the outside to the inside of the knee, and we're sort of covering, you know, half of the kneecap. And we've got a video here, and it might be easier for you know, our listeners on the podcast to jump on the we have a link in the show notes or something like that there. But it's really just 2 strips across the top of the knee there, and you can use that to get out for the run. So
is that putting the kneecap in like the correct position, or
no, it's
deloading under, like, what's it doing?
It's a good question, because that's what we used to say. You know, we used to say it was doing, we're repositioning the kneecap, the kneecap's rotating around. But look, to be honest, we don't know. You know, we don't know really what it's doing. It's very likely that it's working on it, and this is how a lot of taping works. Is it's stimulating the nervous system. So it's sort of, you know, stimulating things. Whether it's distracting you from it, maybe. You know, whether it's getting more muscle activation around there, we don't know. And this is not for everyone. Like, I'll try the taping. You know, and we'll perform a test. Tape it. So say, for instance, we do a squat, you know, what's that like out of 10? Well, that's a 6 out of 10. Okay, let's tape it. Do the squat again for me. What's that like now? Oh, that's a 2 or 3. Great. Okay, well, that taping is going to be good for you. If we tape it and do that movement again, and it's still a 6 out of 10, you know what? Taping, not for you. Don't worry about it. So, but that's where we can try that. We can try that out in the run, and it's a pretty, you know, it's not restrictive out on the run there at all to do. And then once you're home on the run, you can just take it off. So I generally tend to get people to do it only. And
so, can you do that taping yourself, or does it need a second person?
No, and this is the beauty of it too. You can do it yourself. You know, what I recommend is you can just put it up on top of a bed. Just let the knee relax, and then get your 2 strips, 1, 2, and you're done there. So that's the advantage of it. It's really quick and easy, and simple to do by yourself. So that can be a really good one for that pain relief. In terms of our bonuses, so some of the other things that can help, and that I will use for the management of this. So manual therapy, you know, hands-on therapy there. So working around, certainly, you know, soft tissue around through the knee, getting movement around through there, working in other areas, making sure that everything's moving properly, you know, assessing the whole chain there. So hips or back or feet, ankle issues there that can contribute to that. So that's a one that can be used that I'll use for management of this. Also self-massage too. So, you know, massaging around through the quads. Some people find, like with a foam roller or massage gun, can people find that can be quite useful. Don't tend to sort of recommend rubbing around the knee itself, but just sticking around through the thigh muscle, working through the calves there. That can be quite useful. And then orthotics as well. Orthotics can be useful for those with these issues, especially with persistence.
Can you get just ones from the supermarket, or would you be better off getting
and there's some people can benefit from what's called off the shelf or prefabricated orthotics, and they're the ones that you get from your pharmacy or your supermarket. And some people actually find that does give them relief. Other people may need a custom fitted orthotic, and that's where you know, a good sports or a good podiatrist can be really useful here in determining, you know, whether that's something that needs a prefab or whether that is something that needs a custom orthotic. So either or, that it can potentially benefit as well.
In the bonuses, is there any stretching that could help with that?
Stretching, not so much. Like it's
once again, glad to hear that.
It's not so much for this condition. Although if someone's got, you know, if they do have a particularly stiff ankle or you know, mainly the toe or the hip there, then it's stretching
more about
is something.
Mobility there.
Yeah,
really,
it is. That's right. The mobility there, but in my experience, most runners tend to have a lack of strength versus a lack of mobility. There's certainly, as runners, we generally tend to be tight anyway. And so we don't need to be yogis to run. And it's actually an advantage for us to be a bit stiffer.
That's always my excuse not to stretch.
That's exactly right. Mine too. So stretching is not a big part of it, but there are areas and we can use that, but I don't tend to use that as much find the need to use that as much for this. So that's pretty much it. So we cover all those off there. We've got our 4 tips. We've got our running loads, making sure you get those right. We've got our strength training, different exercises going after those areas that you're particularly weak in, running technique considerations, and then also we've got our taping. So
if we find we've got sore knees and it just aches occasionally, just, not all the time, at what point should we come in? When it gets to level 5 pain, or when we're just that odd twinge every now and again? At what point should we make an appointment?
Look, it's. I mean, the saying that stitch in time saves 9. I mean, generally, the earlier we get onto things, the more issues that we can prevent down the track. So, look, I always encourage people to at least get a diagnosis and know what's going on there. And there's sometimes we just sort of say, no, look, this is pretty good. You're doing well. Just keep going, crack on. Other times it's like, well, look, no, there's a few issues that we need to sort out, and we need to work on this particular strength. Plus, it can save some other issues that potentially happen down the track. So I always tend to encourage people to to seek advice early. That may not need to be action from that advice. There may not be need to be too much, but at least just get that diagnosis, figure out what's going on, and then go from there.
If nothing else, it'll relieve your mind so that you know that you're okay to keep going.
That's exactly right.
Otherwise, it takes away from your enjoyment of running if you're paranoid the whole time as well. And like you said, even if you say, no, you're right to go, but just keep your running load at this and increase your strength training, then at least you're doing the right things to prevent it from getting any worse.
Yep, exactly right. So spot on.
Yep. Awesome. All right. Well, thank you so much. So if you have runner's knee, that's what you need to be looking into. And I will put the notes in the show notes, the link to this the notes that you've written, the presentation, yes. And of course, you can have a look on YouTube as well. And of course, anyone can get in contact with you and have an appointment and get these things sorted out straight away.
No, thank you for having me on as well. It's I always love to talk to you, and we'll see.
Well, I've had great feedback. People are really enjoying this series, and I'm sure we'll look at another one of the myriad of injuries.
Yeah, that's right.
Sadly, as I say, but in just saying that, everyone talks about how much runners get injured. In my job as a PT, I speak to most people I hear about being injured are the netballers. Just saying that it's not the runners.
No, that's no.
So we're not as bad as we think we are.
No, you can call this netball knee too.
Yeah,
so it is very common to see. So right across the board, not just running, but even anything.
Yeah, that's right.
Absolutely.
Yeah. All right. Well, thanks so much for your time. We really appreciate it.
Thanks, Isabel. Thank you. Thanks everyone for tuning in. Bye.